Well, good morning or good afternoon, everybody. Thank you for joining us. We're going to give it another minute or so to let people trickle in. So stay tuned and we'll be starting shortly, okay? All right, let's get started. So again, hello everyone and welcome. Thank you for joining us for today's webinar, Protecting Senior Living Communities, the Role of COVID-19 Surveillance Surface Testing. So today we will hear from leaders in the long-term care community who will share the steps that they take every day to ensure the safety of their residents and staff members. My name is Joanne Clovis and I am marketing lead at Enviral Tech. And we are extremely proud today to be working with American Housing Association in sponsoring this panel discussion. And so the goal is for you really to take home actionable ideas on how to efficiently keep your communities safe. So just a little housekeeping before we get started. The presentation today, or actually the panel discussion today, will be about 30 minutes, and then we'll make time at the end for your questions, about 15 minutes. Heads up, you've all been muted from our end, so we do not hear you, but we cannot hear you, but we do want to hear from you. So if you have any questions at all during the presentation, please type them into the question box in your control panel. We'll make sure to address as many of your questions as possible at the end of this webinar. However, if we still have questions at the end of our times together, we will make sure to send you the answers via email together with a recorded version of this webinar. Now, without further ado, we will turn the time over to Dave Schless, President of American Housing Association.
Thank you, Joanne. This is a pleasure to be here. Dave Schless, President of the American Seniors Housing Association. We have, I think, a tremendous opportunity this afternoon. We've got Shula Jaron, the CEO of Enviral Tech, who will be moderating a discussion with Fee Stubblefield, the founder and CEO of the Springs Living, as well as Sarah Silva, who is Divisional President, Community-Based Care at Avamere, both ASHA members. ASHA obviously has been working on several fronts over the course of the past few months, certainly immersed in policy and advocacy work, public relations. We've also been working in other areas as well, a couple of which tied to this conversation today. One was an effort that we did with Ann Tumlinson, and we put together a report and a special issue brief that really looked at the challenges of balancing safety of staff and residents with the need to be sure that we're adequately engaging and socializing our residents. We also recently published some preliminary results from some work that we've been doing with Promatura Group that is looking at directly at prospects and other age and income qualified prospects and family members. And some of that work, which I hope you've looked at, really ties to this, because we asked consumers what it would take to make them feel comfortable to move into a senior living community. And very clearly, the consumers tell us how important it is to have identifiable cleaning and disinfecting programs, and the importance of COVID testing was clear across all service lines. So that really is the backdrop for our conversation today. I began speaking with Fee and Rick Miller from Avamere about air and surface testing, although again, we'll talk about other things as well today as you'll hear. But we began speaking probably back in April, and I think this is an opportunity to share some really interesting techniques and tools that I really think you'll find of interest. So without further ado, I'll turn it over to Shula, and we'll get the conversation started.
Great. Thank you so much, Dave, for having us here today. And so before I go into introductions, I thought that it would probably be good to introduce Enviral Tech, because most of you probably have never heard of us. We consider ourselves the virus sleuths. Our mission and vision is really to keep people safe by making the state-of-the-art viral detection technology, which has existed for a while, has been relegated to research labs and to governmental agencies, but to make that available to the general public so that everyone can have an opportunity to find where virus is in their environments. We're located in Eugene, Oregon, although we serve customers across the United States. We're really focused right now on senior care and senior housing, senior living communities. And we are run by a team of very experienced scientists with more than 60 years of experience in detection technology development. And to give you an idea, so we're going to talk a little bit today about surface testing for viruses, among many other topics. But I wanted to give you just a brief snapshot of what that means and what it looks like when we do virus testing. So we have a kit for surface testing that gets sent out to our customers with very clear instructions on how to collect samples from their hard surfaces in their environments. The second set of pictures here, you can see are people collecting those samples. Those samples get sent back to our state-of-the-art labs, and within 24 hours, we return results back about the status of the virus in the environments of the facilities that we're working with. So without further ado, I would like to introduce our two panelists, Fee Stubblefield and Sarah Silva. So as you probably know, Fee is the CEO and founder of the Springs Living, with its home offices in McMinnville, Oregon. Fee started the Springs Living in 1996 with an idea to build retirement community his grandmother would want to live in as she faced the challenges of aging, and I think we can all appreciate that. Today, there are 12 communities in Oregon and 5 communities in Montana. They offer senior living with options for independent retirement living, assisted living, and memory care. The Springs Living has never focused on being the biggest, but simply to offer the high quality experiences for its customers and employees. Fee embraces the fact that the magic of our profession is in the daily interactions between the residents and direct care staff. The Springs Living has grown organically through acquisition and ground up development. The Springs at Lake Oswego, Oregon, and the Springs at Bozeman, Montana are the newest communities that opened in the winter of 2019. Each community offers a full continuum of living options that include independent living, assisted living, and memory care. So welcome, Fee, and thank you for joining us.
Thank you.
And then Sarah Silva is the Division President of Community-Based Care for Avamere Living. She oversees operations of 30 communities in 7 Western states, including assisted living, independent living, and memory care. Since beginning with Avamere in 2007, Sarah has served in multiple leadership roles, including Executive Director, Memory Care and Leadership Development, Regional Director of Operations, before assuming her current role as Division President. Sarah has over 18 years of experience in community-based care with additional experience in hospice, home health, and home care. Sarah is passionate about enhancing the quality of care provided in CBC across the country, leading her to serve as the Baldridge Quality Award Examiner for AHCA NCAL. She also serves as the Board of Directors for the National Center of Assisted Living. thank you, Sarah, also for making some time today to share your experiences with us. So let's jump right in. I think that we can all agree at the beginning of the pandemic, everything was a bit crazy, and I'm not sure that we were all completely prepared for what was going to happen and how this was going to affect all of our communities. And so, Sarah, I'm wondering if you could look back, what do you think the best decision you made was during the early days of the pandemic, and how has that influenced your company, and what it's doing right now to fight the pandemic?
Sure. I think that we can all agree that the only thing that was certain at the beginning of this was uncertainty, that there was so much that was going on. It happened so quickly, and with information changing and at times changing on a daily or multiple times a day basis as we got to understand the virus better, I would definitely say that the best decision that we made as a company early on was the investment in communication and transparency tools. We knew and discovered early that we were going to have to pivot with changes, with policy changes, with regulatory changes, and knew that we needed a way to communicate with all stakeholders immediately. So coming up with the communication portals to be able to talk to our residents, our families, and our staff, and have that transparency that was a two-way street, where they could also provide a feedback cycle to us to understand what was happening on the front lines as we started to close down our communities. It was critical then, it's just as critical today, and it definitely allowed us more flexibility as we learned different pieces of information about the virus, and we're able to make those changes and keep people informed as quickly as possible.
That's very interesting. So, have you had to develop those tools for communication along the way, or were you implementing tools that you were already using?
It's a combination of both. We were already utilizing a communication portal for our team members to be able to push that information out. And we had communication methods for our residents and families, but discovered that we also still had opportunity for that communication to be more instantaneous than what it was. So really embracing technology and embracing the side of, we contracted with another company that allowed us an instant portal and eliminated the need for communication directly through the community. It really did help show us that in many ways we were still so reliant on, in some cases, a little bit of old-fashioned communication, things like communicating with staff through all staff meetings that you can't have any longer in person. So in some cases, we simply adjusted the technology that we already had, and in other cases, invested in whole new portals for it.
And this seems really important especially for communicating with families who, in many cases, aren't able to come into communities right now. Yeah. So how is that changing for you during this pandemic, and is that influencing any of your how you're dealing with infection control?
Yes, absolutely. The ability to have families communicate both with their loved ones as well as with the team members at a community level in that instantaneous manner has been incredible. We partnered with a company called License that allowed us to have that portal, and I believe that to date we've seen something like 1,600 connections that happened in the first 4 weeks of families to residents that were unable to come in. And one thing that we found is the questions that were coming back to us, much like what Dave already referred to, infection control, of course, is top of mind. So to be able to utilize communication to say, this is what we're doing and this is how we're doing it, and these are the tools and resources that we have available, and then these are the outcomes that we're seeing, that has been incredibly powerful. Because I think, like everyone else, if you're unable to go in and see your loved one, the most important thing was to be able to communicate with that family that we had protocols in place, and if we were making adjustments, we could keep them informed. And this gave us the opportunity to do that. But absolutely, infection control was by far the top question that we received from residents and families.
Mm-hmm. I'd like to talk specifically about the best practices that both companies are using during this pandemic, and how you're keeping your communities safe using these practices. So Fee, what best practices are you using, and how did you develop those processes and protocols?
Well, I think, Shula, what you said at the start, when this broke out, we were all guessing. We're still guessing in some ways. And I think one of the key things to not only help us develop what we were doing then and what we're doing now is what Sarah talked about, is communication. Kind of a key point for us was communication. I think all of us as operators have done very similar things. I've listened to a lot of webinars and I've read a lot of articles that are out there. And from being in senior housing and care in our profession, there's a big spotlight on us right now. And so I think from what I've seen is everybody's done a lot of similar things. We've gone through a very logical process, and this country's full of a lot of great operators that do a great job taking care of people every single day. We don't always get recognition for that. And so one of the things that I did in similar to all of my peers out there is talk to each other, right? Communication was the key, and particularly communication with a lot of local operators here in Oregon. And I think a particular turning point was in a conversation with Rick in discussing the possibility of testing, and particularly what you guys were developing in service testing. And we did our first human tests in early April with one resident that had an infection. And at the time we had the discussion, Shula, I think you were on the call. We got on the call and you trying to figure out how this surface testing could work. And I was not a believer in it. I was thinking, hey, human testing is where it's at. I just don't need to see the surface testing, because at the time we didn't know how this virus transmitted so rapidly with asymptomatic spreaders. And so human testing seemed like the thing for me that we needed to focus on. In the end, my view was switched. My view is human testing is absolutely critical, but the process that you guys have developed with surface testing as an early warning sign, and the studies that the Springs Living has participated with Avamere and Marquis are extremely revealing to the fact that it gives us a 5 to 7 day lead time. And so our protocols really developed around that and the results we got, and they're developing on the fly as we learn more information, we get more information. I mean, our protocols around cleaning. You surely remember when we did that first prototype test at one of our communities, and we had a resident that went to the hospital and was positive, and so we went in there and cleaned their room with a commercial cleaner. And you came in and did a test after we cleaned, and you just wanted to verify some things, and you found COVID in a building, in an apartment that had already been cleaned. That was a scary time for us. So we had them come back and we cleaned again, and you came back and guess what? We found it again. And finally, you guys came and you cleaned and helped inform our cleaning methods. And we were using recommended cleaning methods to do this, and it's still showing up. And that's a scary thing. It's on the inside of the air ducts. It's on surfaces that were touched. It was on keyboards of the resident computer, and it wasn't going away. Now, to the amount of infection on that and whether it's contagious or not is another story that we're still learning about. So I would say that Enviral Tech's been a huge resource for us in developing how we fight COVID and how we're fighting COVID today, which is through weekly testings of every single one of our communities. And then when we get a hit, thank God this week we didn't. Last week we did, and we were scrambling. Then we used surface tests or human tests to kind of bracket where it came from and get those people that are positive. In our case, everybody asymptomatic over the last couple months, and it gives us that warning time, and we can stop the outbreak or minimize the outbreak is what we found.
So it sounds like there's a few different key parts to the process that you use. So there's the surface testing, but there's also the human testing. Can you talk a little bit about how those two fit together, and what other components are there in your process that you feel are really important that have helped you in the fight?
Well, I think we decided early on that we were going to assume that every surface was contaminated and every person that walked in our communities was asymptomatic positive, and we responded. We started burning PPE very early, but we really didn't have any visibility of what was really there. When the serving testing option came up, and I think it was when we participated in that study with you guys. I think the first surface testing, we had done some before that, but the first of the official test was, I believe, on May 14th. And, you know, it was really interesting. May 14th, May 19th, May 26th, negative, negative, negative in every one of our communities. We did a census. We did every single one of our communities. And then on June 2nd, we got a hit. And so that was the first time that we said, okay, what we have to do now is we've got to use human testing to find out. All we knew is that it came in the building, right? And what's really interesting in some of the information that we've seen, where our the data that we have is, it's in staff and in memory care is our biggest rate of infection. We know that if it's going to get in, the staff are going to bring it. Our memory care has had as a percentage, had the highest amount of COVID in it. And so we didn't know who it was, but we found through testing there's certain groups that are more vulnerable of employees to spreading it. For example, our med aides. Our med aides are the highest percentage of employee that have tested positive, and they go from obviously from resident to resident. So it's a very important group to have very health focused and protocol focused. So we, at that point in June, we used human testing to really bracket, and we did it. We developed our protocols where, you know, all of us have limited testing that we have access to. And if what we're experiencing here in Oregon is similar to what the rest of you are, is that there's more demanding on testing in the labs. The longer and longer time for human testing, it's taking longer to get the results back. And if you're in a building and you know through a service test you've got COVID, but you're waiting for 3, 4, 5 days for a human test, that's just, one, it's expensive, but more importantly, it's potentially costing lives. And so, but at least it gives us the ability to enhance those protocols, to go to a higher level of infection control. When we know we have negative surface tests, it allows everybody in the community to just be more relaxed. And then when we get a positive one, we use human tests to kind of find it. So that's how we've used it.
Thank you. So Sarah, I know that testing has been a little bit different for your communities. How has your testing needs changed during the time of the COVID, and what are you guys using?
Sure. They have changed. I think they've changed for all of us. You know, in the beginning, as we were learning more and more about the virus, testing was a very reactive process. Testing was only available for symptomatic carriers. So you didn't even have the availability to do testing unless you had somebody who was already symptomatic. And as we have learned through the course of the last couple of months, the role of the asymptomatic carrier is what is so dangerous to our communities. So a combination, you know, we went into surface testing already doing human testing. So we were beyond if you had a symptomatic employee or resident, then we did all human testing for the community anyway, and then moved into surveillance testing for our staff as well. The opportunity to do surface testing, we really went into that with the mindset of, we want to know more about how this virus works. We want to better understand how it stays on surfaces. We want to better understand our cleaning methodology. We want to understand if there are more or better things that we can do to prevent COVID within our communities. And like Steve said, I feel like we did learn a great deal through surface testing. Both surveillance human testing and surveillance surface testing really provides us a much more proactive measure for COVID, as opposed to how we all had to operate in say March or April. And really for us, the way that we developed this protocol, we had a very similar story to Fee, which is that one of the things we learned as starting to get positive results on surface testing, which was then followed with human testing and not finding the virus in humans, was really a better understanding of cleaning protocols and a better understanding of how you monitor outside providers. knowing that we already screen providers as they come to the door, but you don't have that opportunity for testing within critical outside providers coming in the way you do your own staff. And it really led us to make changes in both our cleaning protocol in some of those heavier traffic areas, particularly, as Fee mentioned, heavier traffic areas that are really touched by the med techs, which we agree are probably the most critical point in the building for potential for spread, things like the med carts in particular, but then also the ability to change our screening for outside providers, in most cases moving it completely outside of the community, realizing that even through the screening process that they were leaving COVID behind while they were passing the mandatory screening. So, and that was information that outside of surface testing we never would have known. And so it has been incredibly beneficial in that way to be able to allow us to make those adjustments to cleaning and feel better about the fact that, you know, we can certify now that these services are clean. So even as we are doing human testing and can say that our staff are not positive, we can now also say that we understand and have the results to be able to show that the surfaces that may be touched by people outside of our control are also being cleaned.
Is there a difference between the assisted living and the independent living communities that you have in terms of the protocols that you're using, how you're using testing in those communities?
There's no difference in how we approach an assisted living or how we approach an independent living when it comes to testing, when it comes to cleaning, when it comes to the response. The key difference is understanding that there's a lot more movement in independent living, a lot more residents that are going to come and go out of a community on any given day. So if anything, I would almost argue that the need for surface testing is probably higher on an independent living side, because you're just going to have more interaction with the public in independent living. Your residents are going to have more interaction with the public. And as we continue to see COVID cases on the rise in the general public across the country, we know that while in assisted living or memory care settings, our staff are the highest risk for bringing COVID into the community, in independent living, really what we have found is that it's actually the residents that are the highest risk of bringing it into the community. And in that case, that more proactive testing becomes even more critical.
That's a good distinction to make. Fee, it looks like maybe you had something you wanted to add to that.
Well, Dave started this out about confidence in the market for our customers. I think all of us have seen declines in occupancy. We've had to stop moving people in. Hopefully, everybody out there is able to start moving people in. I think surface testing for us has given us the confidence in the market, the confidence to allow people to move back in, because we get that neat little certificate that you have there, Shula, and we post it at the front door that shows that this week all of our services came back COVID free. It's very powerful for our marketing people to be able to offer that confidence, and it's powerful for the residents that are in there. So I think it's one of the key things. It's one of the tools that we must employ, I think, on a more regular basis, just to give the market confidence. And it's a lot of it is yes, it's given us real life impact, being able to spread out or stop an outbreak. But the other thing it's doing is what it's doing to perception and psyche is that, for example, the Springs Living, we're tracking our year-over-year mortality rate. We just looked at the last few years. We're over last year, the mortality rate for move-outs due to death from all of our residents, independent, assisted, and memory care residents, is down 2%. So 2% less deaths in our communities, right? And we know that's a fact, right? We know our fact is our infection rate for all residents and all employees, total lives that we impact, is 1.27%. Our mortality rate is 0.08, not even 1%, right? And so the facts are, people in our communities are safer than they were last year. I mean, they're not dying of flu and colds, and we know this, but this story has to get told. And I think surface testing really allows that psychology, that sense of safety that's out there. There's a lot of fear, and fear paralyzes people. And we found that this is a really effective tool of getting things to open up again.
Okay, so I want to give the audience a chance to ask some questions of you. I've got a couple other questions in case there aren't any in the audience. But does anybody in the audience want to ask Fee or Sarah a question about their protocols, anything about their experiences?
Yeah, so we have one question. So somebody's asking, surface testing sounds very compelling and it's great if you are trying to clean up, but one of the important items is to prevent asymptomatic people from coming into the building. So one of the options that are out there to screen asymptomatic people is pulse oxygen test at entry point. Is either of you two using this method at all?
We're not using it. We've heard about it. We're investigating. I think there's some really exciting technology going on out there, and some options that are there. I know that we've got air, Shula can talk about it, air monitoring, equipment and tests coming. There's new things. We're evolving every day. We're going to have more tools every day. We're currently not employing that, but we will as soon as it's available.
How about you, Sarah? Oh, sorry, we can't hear you.
Because I muted myself, we are not employing that technology today, no. But much like Fee said, with the entire COVID team within Avamere that's constantly looking at the changes and what is available to us, we employ that technology as it's proven and as it makes sense to do within those settings.
I think one of the things for us is that there's a big error rate in all these tests, human tests, human tests in particular. There's the false negatives and so on. And so I think we got to use as many tools as we can. Anything that's available, we have to use to fight this. And it's not just COVID-19, you guys. We got to do this because we have to evolve. There's going to be COVID-20, COVID-21. I mean, this is going to continue, and we have to build those walls and create safe places and give people confidence that our communities and our environments and the services we offer are the very safest place for people to live.
Another question is, what did you change from the recommended cleaning protocols to get rid of COVID at the end?
I assume that's for me. When we found out that the first testing, we were using a commercial cleaner that was using a CDC recommended cleaning surface. And Shula, you want to talk to that? You probably have a better,
Sure.
You can probably be more accurate with that information.
Sure, yeah. So I think at the time you guys were using a fogger to fog the space, and I think since then actually some of the recommendations have changed from the CDC, and they recommend doing surface cleaning, so trigger spray and cleaning. And so that was a big change that we helped you with, was identifying that the fogger wasn't sufficient, that maybe the fogger plus the surface, the direct manual surface cleaning was going to be important. And so that was one part of it. And then the other part was looking at the different types of cleaners that were out there and identifying ones that would fully remove viral particles from the surface so that you could be confident that there was no virus left behind. And so that was the other piece, was identifying which cleaners would be the best for the trigger spray and manual wiping.
Okay, Shula, I'm going to hand the mic back to you.
Okay, great. So I'm sure that there'll, even if somebody hasn't asked it already, that the question is out there about the economics of testing. And so Fee, I think Fee and Sarah, both of your companies have been testing quite a few of both the staff and the residents in your communities. But I was wondering maybe, Fee, if you could talk to the economics of the testing, including the surface testing, and what what does that mean for you?
You want to start, Sarah?
Oh no, go ahead, Steve.
Okay, all right. So what we found is that the surface testing is a great way. Of course, we're in states where the government is mandating tests of employees and residents. In Oregon, it's going to be a process between June 1st and September to test employees. And in Montana, we have to test every resident. We've tested 70% of our communities already. There's some NIC information that came out that we've tested a lot more than I think the national average is. And we really think it's a key to understand where it's going. But the way that you guys do the surface testing and the way they're talking about doing future human testing where they use the pooled system and the way that you use your surface test as a pool you get more, you just get more surfaces. If a pool becomes positive, you can narrow down to what surface was positive. It just is, what's really great about it is the economics. First of all, the economics of preventing an outbreak are compelling, very compelling. It's very affordable, these testing protocols, compared to the numbers that I'm hearing. If you get a real outbreak of a significant percentage of residents and you get a high mortality rate, which we know the mortality rates can be up to 25% or higher. And so from that perspective, we've taken the stance that we just have to make it happen because it's a far better, the math comes out far better if we prevent an outbreak than we have an outbreak.
Sarah, did you have anything to add to that?
Yeah, I completely agree with what he said. I mean, at the end of the day, there's no price that you can put on preventing an outbreak. There just isn't. And I understand that the reality of the reality of doing business is that you have to be able to keep your doors open. But a single outbreak in a community is absolutely catastrophic, both from a financial perspective, but more importantly from a loss of life perspective. And as we continue to move forward and see COVID that is expanding within the states, and I think especially moving forward even a couple of months, looking into a new school year where we're going to have an incredible change in our staffing availability if students are unable to go back to school. And there are so many different factors today that impact us financially that we have very little control over. This gives us an opportunity to have some control. And even if that means that we are expanding our expenses to pay for surface testing, to pay for surveillance testing, to pay for just the standard PPE operating as if you are COVID positive, those are all, yes, they're expensive up front. None of us can deny that, but none of that is as expensive as either having an outbreak or goodness forbid, losing a life.
Shula, I have a question. I'm gonna jump
Sure.
in. So one of the things that I'm just interested, actually two-part question. The first is I'm interested to know in any given week, what types of surfaces are you testing? Obviously, these are, in some instances, probably campuses. And then I'm also interested, obviously, you've got now, some data that you've been collecting, and I think the members would be interested to know, like, obviously you mentioned the carts, med carts. Where are you testing, how frequently, and what are the things that you're seeing maybe beyond the med carts that, that folks would be interested in knowing about?
Sure. I can answer that one pretty easily. Within our settings, we did a combination of testing amongst campus settings, standalone independent living, standalone memory care, or then the campuses with all three present. What we found pretty consistently was that if there was consistency to positive tests, what we found was the med carts in assisted living in particular, and then really the shared staff space, which things like coffee pots, time clocks, things that we were cleaning frequently, and yet still on occasion still popped up positive, which then could be an indicator that we then needed to go in and test staff members that may be carrying it. The other piece is really probably not overly surprising, but the front door, right as people were that outside provider piece, that front door, front desk. Again, despite the incredible cleaning that happens in those areas, just knowing how frequently that front desk gets wiped down and to still come back positive was incredibly eye-opening and did lead to the change in how we needed to clean that place.
Dave, I think one of the really important things that we got to realize is that while we have controlled and the ability to, somewhat the ability to require tests and test our employees and our residents, we don't have the ability, and a lot of these government mandates aren't covering these third parties that are a vital part of our communities. And so how are you going to know if you get a positive person coming in if you can't require them? We've been, I don't know about you, Sarah, but we've been in some battles with some outside vendors about, you know, insisting that they get their people tested where they weren't going to get their people tested because they were asymptomatic. And, you know, that's a deep concern. The surface testing allows us to, and everybody needs to realize that Enviral Tech is extremely sensitive and extremely accurate. They can pick up just very minute amounts. One of the tests, we had a positive hit last week in one of our communities on a handrail. So we're experimenting with the right protocols of where to test and have a certain randomness about it, make sure that the same area is tested every single time. And we had a positive result that came in. And so we immediately went into our full protocols and, you know, went back and you know, restricted movement, access, full PP, all that stuff. We got our human testing in. Fortunately, last week it was a better turnaround times on human testing, and everybody was negative, right? And so where did it come from? Did it come from an essential visitor, a family member coming in with a resident on a hospice, or did it come from a you know, a hospice or a home health worker? I mean, where did it come from? In the end, you know, maybe we prevented it, you know, by acting quickly. I think, you know, some of the interesting things, and I've got a really neat screen here if you want me to show you. I think I can still show my screen, Dave. If I go to this screen right here, which is one of our communities, if you all can see that. Oops, did it go away? Can you see the chart?
Yeah, we can see it.
Okay. So basically this shows you one of our communities. We started here on the 14th, this green here, if you can see my cursor, green is good, right? No COVID, no COVID, no COVID, boom, COVID. Well, these are when, and so we were able to identify through human testing right here in June 2nd and 3rd in this community, who the asymptomatic people were, get them out. None of them showed any symptoms until June 9th. So that gives us 1, 2, 3, 4, a 5-day in that instance. We're finding this 5 to 7 day early warning system to get protocols in place and to take care of people quickly when you do the surface testing. And what's nice about it, as we get more and more demand as we come into fall and potentially we're going to have another spike, we don't know, is that these are using different labs than the human testing labs. And so there's capacity out there to get this information. Even if you can't get your human testing results back, the turnaround time for the surface testing has been spectacular.
And actually, to build onto that, I have a question from the audience, which and so they're asking, one of the big concerns with human testing has been the reliability of the results. And so does surface testing have the same challenge? And that might be for you, Shula.
So the surface testing does use the same technology that the human testing does. So it's a qPCR based test that looks for the genetic material of the virus. And so there are some challenges still with this technology. However, what we've found was that we are very sensitive and very accurate with our tests. Some of that data is published on our website to know exactly what those numbers are. And the difference is that when you take a sample from a person, you have to be sure that you're getting a sample from a spot in a human that actually has COVID virus in it. And so you can very easily get false negatives. We're finding with like nasopharyngeal swabs, where we think that maybe that's not where all of the virus is harbored, as opposed to the surface testing, where if somebody has passed by and is shedding virus and it's collecting on that surface, we'll test it. Of course, You know, there are the drawbacks that if you don't test a surface where somebody has shed their virus, then you're not going to pick that up as well.
Thank you, Shula. And so another question, kind of leading to the financial part of it, is, you know, what is the right regimen for surface testing, and eventually like the cost of it?
Yeah, so you know, I think that the companies and the communities that we're working with have found that 1 to 2 times per week, and that really depends on the level of risk in the community itself. And so that they take into account, and Fee can probably talk about how they've designated risk for their different communities, and then how they've identified how frequently they want to test using surface testing and human testing. And so that's, you know, we recommend roughly once a week or maybe a little bit more frequently for the surveillance type testing, where you're trying to identify when the virus is starting to enter your facilities. And then we are, one of the goals for us is that we know that this is a really important tool in the toolbox that people are using to fight this outbreak. And so we try to be as low cost as possible so that it's affordable for companies. So Fee, do you want to talk about how you've identified risk for your communities?
Right. So, I mean, we only have so many resources and we have to use them well, including human tests and surface tests. It's all expensive. So what we've done is we've created different priority areas based on county health information of outbreaks. And so if we've got a hot area, we're doing our surface testing multiple times a week. Right now we're doing, I think right now, until we get the data, right now we're being very conservative, and we all must be very conservative to restore that confidence back and keep people safe. And so we're testing every community every week right now. And if it's in a hot area, then we're going to be more frequently. We're also going to, if it's a hot area where we get a hit on a surface test, but we don't have anybody symptomatic, we're going to increase the percentage of testing for human testing too, certainly by employees. But yeah, we do. We kind of have a low, medium, and high ranking, and we have a protocol that then dictates what our testing regime is based on that. You know, and then we'll see what the results are as the results go. And you know, and when I say results, not just positive, but I think what we all have to track too is, you know, what is the impact on mortality here? What that's the real bottom line number. Is, you know, is what's the damage that this is doing. And so I think right now, until we get better information, we all must be very vigilant and err on the side of conservatism in testing, and being very prudent. As we get more information, then we will start relaxing and go from there. But that's how we've developed it, so that we didn't, like in Montana's at an extremely low case number. They are spiking a little bit right now, and so we're starting back to some protocols the governor's even thinking about. I heard today restricting access again, and rolling back some of the openings that have happened up there, and so we'll go to testing a little bit more there. But even there, you know, we want to. This is so new that we want the data. We want to see what's happening so that we can tell our story. I think that's the other thing that's important here. One, it's saving lives. Two, it's really being able to communicate and tell the story that actually, I mean, and we're very fortunate. Sarah and I operating in areas that, you know, some of our peers that we spoke to on the East Coast, we feel for them, because, you know, we've been very fortunate out here in the West. We know that we haven't had to the extent that other people have. And so that's kind of how we've been doing it, Shula.
Great.
Are there any other?
Oh, did you want to add something
Sorry,
here?
I was just going to ask if there were any other questions from the audience before we wrap up.
Let's see. Yes, we can pick one more. So we have with varying sizes of communities, is there a recommended number of test kits to be used each week based on square footage? So Shula, you said.
Mm-hmm.
once or twice a week? Is it based on square footage at all?
So right now, because most of these communities are fairly locked down, we're really focusing on the common areas in the facilities and the staff areas, because as Sarah pointed out earlier, that in assisted living communities, it's really the staff that are coming in and out, and then in independent living communities, it's the residents. And so those residents, where we can pick it up the best is in the common areas, and then for the staff, it's in the staff areas. So it's not really based on square footage at this point. It's more based on the number of areas that you have that fit that description.
And I'd add to that, Shula, that we found that we've added more tests. We have some communities, some of our early communities we built that are smaller buildings. They're more cottage style with 12 apartments. Those are a lot more expensive and a lot more intensive to test. I mean, they have good things because you can contain things in a smaller building better, but you also have to test every single building. Because with our protocols in some of these areas, we don't allow staff to go into separate buildings. They have only one building that they work in, is one of the key things that has helped us contain this and not spread it. So we really look at it's really a decision on our part based on each unique building. And we can actually, in a bigger building, we can actually get away with less tests or equal to or less tests in some of our smaller buildings that have multiple distinct common spaces.
Shula, I'm gonna also jump in with a question since we have maybe a couple minutes. As the buildings start to open up, I'm just interested, not necessarily related to testing per se, but be interested in both of your thoughts, Fee and Sarah, on how you're looking at the issue of visitation and people coming and going, and obviously we know it's tricky and it's important.
Yeah.
Sure. I think that you're right. It's tricky, but it's critical. Our residents need their families. Our residents need to be able to see their loved ones. That is important. And one of the unique challenges to our senior living setting, going back to the very origins of it, was that residents have choice. And residents have freedom, and residents have independence, and they choose our setting over a SNF setting for that very reason. So being able to understand that is the key factor in why someone might choose to live in a senior living community, is the ability to make those choices for themselves, good or bad. And that includes seeing their family. And I think the reality is either we can figure out a way to have them safely visit their family on site, or they're going to leave and go to their family's home to conduct that visit. And if you know that that's the reality, then it's our job as an industry to find a safe way to visit and allow that socialization and that interaction, because it's critical to our residents' health that they have that socialization and interaction with their loved ones. So we've really approached visitation with families where, in many cases, from a regulatory environment, they still can't come into the building. So we simply create visitation space for them in the exterior of the building where that's allowed, in all of our independent livings. Just creating a safe environment for people to still be able to come and potentially even eat a meal with their loved one, but in a separated and safe space that we know that they may not be passing the virus back and forth to each other. So I think it's critical that it happens. And I think either we control how that happens in a safe way, or residents are just going to leave our buildings to get that socialization.
Yeah, I'd say, Dave, I agree with that. I mean, we've seen far more move outs from significantly far more from just limited restrictions that families and residents just don't want to have this phase of their life without their family. They choose to move out, and we don't have a choice to try to accommodate that in our communities because we have to comply with state and local agencies, right? And we have to balance these sometimes conflicting requirements between the health authorities, the counties, and the state agencies, and it's very challenging, and it puts a lot of stress on our families and us. People are trying to do good, but they're a lot of times they create challenging things on a macro level that they don't understand on a micro level. Listen, who's going to protect their family more than their daughter right? The resident's daughter or their son. And so, we've, in compliance with all the regulations that we're required to do, frankly, we see this as the biggest issue. We're seeing much more declines in health and attitude and just willing to live from residents when they can't see their family. And so in the states and areas that we can, I mean, we consider families very essential visitors. If we see a decline in health of a resident, we've got to get people back in here. And we have some very strict protocols, including testing and screening. And, families are more than willing to get tested, even if they have to do it every week to come in the door. And so having all these different testing things, and certainly if we can show that our community is COVID free, it gives everybody, gives the family more feel better. It just allows us to be more impactful. But this is the biggest challenge that we have. We must have family access to residents. What is life? The quality of life is so dependent on relationships, and we have to use these technologies. And we have to use we have to trust family, and we have to trust the professionals that we have working in our communities to make the right decisions. And so we're doing everything we can to make that happen.
Okay, so I think we might be out of time. We've run a little bit over time. Thanks to everybody for joining us, and thank you to Fee and Sarah for being willing to talk about your experiences and best practices. And thank you, David, for hosting.
It was a pleasure, and we thank all of you, and maybe we'll follow back up as we get into this a little bit deeper, but we thank you for your time and appreciate your sharing your thoughtful insights with us today.
Thanks, Dave. Thanks for everything you're doing out there.
Thank you.
Thank you.
Thanks.
Shula.
Thank you, everyone. And I will be sending a recording to you guys in a couple of days, probably today or tomorrow. So stay tuned.
Great.
Bye.
Thanks, bye.
Bye-bye.
Bye-bye.
Bye.